speakers from the sessions to come on up. We don't have seats for everybody, but everybody come on up. We've got about 10 minutes for questions. 7 or 8 minutes for questions. So while we're bringing people up, are there questions out in the audience for any of the speakers from the session this morning? Celeste. Keytruda.
What is it? Who developed it?
So, I'm a simple person, so I explain things simply.
Come on up here.
So, in your immune system, there are ways to recognize foreign things. Your immune system has a lot of checks and balances built in. One of them is a friendly fire signal. So effectively, when an immune cell recognizes something as foreign, if it's actually inappropriate, if it's you, it sends a friendly fire signal and says, hey, back off. Effectively, these drugs block that friendly fire signal. And so the idea is your immune system wants to react to this cancer, it wants to take it out, but what's happened is, because this is you, remember, this is access to all of your sort of Pandora's box in the occult book section, it's actually putting up friendly fire signals at the same time as it's also putting up danger signals. So effectively, by blocking that friendly fire, you allow the immune system to try to do its job, and that's why one of these things you'll see is a common theme. Folks who get radiotherapy, for example, or other cytotoxic therapies, you kill a bunch of cells about the same time as you're taking the brakes off the immune system, and we can get an effect. But as I think everyone has said, we're in the infancy. We understand that this can happen. When it happens, it is literally miraculous. And when it doesn't work, it's worse than water. And it's completely unclear what really separates that at this point.
I have a question just about some of the early detection, and I wonder, you touched on it a little bit, Dr. Oliver and Dr. Todd, are there model programs in place today that you can stress to other worker organizations or unions that have been successful in early detection that hopefully you can take to Congress someday and have the insurance industry wake up and pay for it? And I'm just wondering how, with the insulin, how is it being paid for if the insurance industry is not, so we can use it for a model?
The answer to your first question is the only models out there are really based on lung cancer studies. We don't really have the time for the public, for the task force to do an asbestos study, so we're doing it ourselves. But in New York, for example, we're doing everyone over 40, and there is no smoking criterion, and we're doing the spouses as well. How we're paying for it, some of the locals try and run it through insurance. Most of them just say, forget it, we'll pay for it, and they're paying for it themselves.
Just to comment on that, I think you're going to have to, it's going to be very difficult to get the insurance companies to pay for it, in my experience. And there's an organization that met and published recommendations called the Helsinki Criteria, and they addressed this issue in 2014 with regard to individuals and populations whose risk for lung cancer comes from asbestos exposure and not cigarette smoking. So what was required to get insurers to pay for LDCT screening for cigarette smokers was a randomized controlled trial. And so if they require a randomized controlled trial in order to get insurers to pay for screening of those whose risk is from asbestos exposure, it's going to be 10 to 15 years before it's ever done. And so I think the only thing we can hope for is that as we do medical surveillance on the group at Mount Sinai, which is being paid for by the insulators, then you can accumulate data that will provide support for low-dose chest CT screening for those whose risk is due to occupational exposure to a lung carcinogen, whether it's asbestos or hexavalent chromium or silica or, whatever. So I'm hopeful. I mean, I think this Mount Sinai group will provide that basis.
I just want to add a couple of comments there. If you think about it, there's 2 programs that I know of that are paid for by the federal government. Actually 3. There's Dr. Black's program at the Card Clinic where there's now monies coming in to help do some of the screening. But you've got the World Trade Center group, which is not, any one specific union, but a very specific group with funds there. And then you also have people who are part of the nuclear industry, where the Department of Energy is doing a program among former workers screening for disease. So the problem here is that these are discrete populations that somebody has lobbied for, that with the DOE workers, they've even set up a compensation program if you've got what's thought to be a work-related disease. So it is not yet universal, but this may be a situation where for things like asbestos exposure, and there have been obviously previous examples, black lung, where unions, for example, could come together, pressure for some funds for screening to look into these kinds of problems.
Time for one more question.
One more question. Fernanda.
Please, I would like to know, what about the costs using Keytruda comparative with the conventional treatment, Alinta and cisplatin? How much it is in general?
So all of these, Amento is not at all cheap in terms of what's billed. The Keytruda is expensive. There's a couple of ways to look at it. One of them is that if you actually do the public health days of life saved and versus cost, they're reasonably cost effective compared to lots of other things we do. The flip side of that is though people who say we ought to be able to do this for cheaper, we ought to be able to do this better, we ought to be able to get this to the point where everyone can have it, so you could just try it if cost were no objective. So I mean, there's clearly two sides of that coin. They're not cheap, but at least they're within the line of all the other things we're currently doing in biomedicine.
Dr. Frank, before we close, it would be really important to Lou Williams, if you would all, we'll send the link out on our conference update page for everyone to sign the petition. Paul's smiling. She's worked for over a year to have Keytruda be acceptable, and they call it a PBS scheme, so that patients can access it. Paul is doing this out of pocket as well, correct, Paul? So for those people who need this drug, it is a cash basis, and it can be upwards of $6,000 to $8,000 a treatment, is what I've been told. So that's just signed Lou's petition.
Much more than that.
Well, per treatment. Yeah.
Alimta, cisplatin, my chemo treatments 10 years ago were $25,000 per treatment.
Right.
And that was for Alimta and cisplatin.
Yeah.
And that was, so I racked up over $100,000 just in chemo for 4 sessions. Keytruda is even more expensive, from what I understand.
I'm sorry. I signed up to do it out of pocket. It ended up that I just turned eligible for Medicare and they approved it. But it's billed by Merck at a little over $22,000 per injection, plus there's the clinical costs. So, but Medicare, I think their approved payment is a little over $6,000.
Okay. Thank you to all the speakers. We're going to call this session closed and move on to the keynote. So thank you all.